we need to think about our why. That's really important to identify why we have breast cancer, why we have dysfunction. Health is not the absence of disease. Health is optimal function, and that's our goal, to get you back to optimal function. Stop focusing on the tumor, focus on the inflammation, focus on why you're inflamed, focus on what could be driving the process, ask a lot of questions, but then think about getting those pillars into place. And that's what my book is about. It's about putting those pillars in place, teaching you how, when, and what to eat, how to move, how to sleep, right?
Dr. Jenn Simmons is an integrative oncologist, author, podcast host, summit host, and founder of PerfeQTion Imaging, PerfeQTion Imaging. Dr. Simmons started her professional career as Philadelphia's first fellowship-trained breast surgeon and spent 17 years as Philadelphia's top breast surgeon. Her own illness led her to discover functional medicine. So enamored with the concept of creating health rather than killing disease, she left traditional medicine in 2019 and founded Real Health MD to help women along their breast cancer journey truly heal. Welcome, Dr. Simmons. I'm so excited to have you on Take Back Your Health. Well, welcome, Dr. Jenn Simmons. I am so excited to have you on Take Back Your Health with Dr. Amy Myers.
I am so excited to be here. I have been so looking forward to talking to you and our conversation. So I'm just grateful to be here.
You, like many of us in functional medicine, have your own story. You were trained as a conventional surgical oncologist, which is super cool, and then moved into functional medicine. So I'd love to start, for those that are not familiar with you, just to hear your story about how you made that change and why you made that change.
So I'm sure that I'm like you and everyone else who makes this shift, in that I have a pain to purpose story. But being in the breast cancer space was always where I was intended to be. So I really don't remember a time in my life where I didn't know about breast cancer. Growing up, I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She wrote all the music for the Spinners and the Stylistics. She was beautiful, brilliant, a beacon of light, the queen of Motown sound in Philadelphia. And she was my hero. She wrote 54 hits in all, and her most famous song was The Greatest Love of All.
Oh, wow.
So, when I tell you that my cousin was a rock star, I mean my cousin was a rock star. And she wrote The Greatest Love of All in 1977 as the title track to the movie The Greatest, starring Muhammad Ali. But we all know that it really received its acclaim in March of 1986 when Whitney Houston would release that song to the world. And at that time, it would spend 14 weeks at the top of the charts. Only Linda would never know, because Linda died of metastatic breast cancer 1 month after Whitney released that song.
Oh,
I was 16 when my hero died. And her life, and ultimately her death, gave birth to my life's purpose. So I did the only thing I knew how to do. I became a doctor, the first doctor in the family. I became a surgeon. I became the first fellowship-trained breast cancer surgeon in Philadelphia. Say that 5 times fast. And, I did that really well for a long time. And in my 15th year of practice, when I've already diagnosed my aunt with breast cancer, diagnosed my mother, I went from being super duper high functioning to basically I couldn't walk across the room because I didn't have the breath in my body. And I have this intensive 3-day workup. As any physician that gets sick gets thrown right into the system, and lots of VIP testing. And at the end of 3 days, I'm sitting in the office of my friend and colleague and physician. And he tells me that I need to have my thyroid removed, and that I need chemoradiation, and that I'm going to be on lifelong thyroid hormone replacement. And despite the fact that these were things that I said all day, every day to people without hesitation or reservation, when those words are coming at you, they have different meaning. And all I could think of in that span of time is there has to be another way. Why would God give me an organ to remove it, radiate myself, and then be dependent on synthetic hormone replacement for the rest of my life? It just didn't make sense. And I went on a journey to find another way. And I got on a very fortunate path.
Do you mind me asking real quick what year this was?
It was 2017. And I decided that I needed, first I went to Dr. Google, which at that time, Dr. Google was far more reliable than Dr. Google is now, because the narrative now is being so utterly controlled. And that's a conversation for another day. But at the time, I Googled, how do I heal my thyroid? And the same thing came up again and again and again. Of course, your name came up, but diet, right? Diet. Now, as a conventionally trained physician, we get 15 hours of training around nutrition. It's typically in our first year of medical school. That's when it was for me. And literally never again. So they teach you about scurvy, and they teach you about rickets, and they teach you how to write for IV nutrition. And that's basically all they teach you. And I had a lot of training beyond my first year of medical school. I'm a fellowship trained surgeon. So I have 4 years of medical school, 6 years of residency training. Like, this is no joke. The fact that we had no training beyond that told us what was very intentionally taught to us, which is food isn't important, right? And when we are in medical school, we truly believe that if it's not taught to us, it's either not true, not important, maybe both. So I came up believing that nutrition wasn't important, and yet here I am at this crossroads, struggling with my health, clawing for my health. And I'm hearing time and time again that I need to change the way I nourish myself. So I enroll in this certificate course because I still want to keep my job, and I still want to be a wife and a mother and all these things all these balls I'm trying to keep in the air. So I enroll in this certificate course, and I'm sitting in one of the very first lectures, and this tall, lanky guy with this big toothy grin comes on the stage and introduces himself as a functional medicine physician. Now, at this point, I'm a doctor for 20 years. I'm like, there's no such thing as a functional medicine physician. What is this quack talking about? Turns out this quack is Dr. Mark Hyman, who in 2017, though he had written plenty of best-selling books, they had not come to me as yet. I had no idea who he was. But I did remember that I was sick, and I was there for a reason. So I check my ego at the door. I shut up. I tune in. I listen. And thank God I did. Because what he was saying was actually telescoping the rest of my life. Not only how I was going to heal myself, but how I was going to heal my patients. Because what I learned on that day was I was completely focused on the wrong thing, as we all are in the conventional cancer world, because all the focus is on the tumor. But the tumor is not the problem. The tumor is the symptom of the problem. The problem is the chronic inflammation. The problem is what is driving that process. Cancer is a normal response to an abnormal environment. And we have serious problems with our environment. And so on that day, I kind of had my blinders taken off. And I'm an early adopter. I'm a quick start. And I joined the Institute for Functional Medicine that day and spent the next 3 years immersed in the study of functional medicine. And for me, it was a bell that I couldn't unring. And when I was finished and when I was certified, I walked away from my very respectable position and opened up a functional medicine practice aimed at helping women anywhere along their breast cancer journey to recover their health. And quite frankly, I mean, people ask all the time, do you miss the OR? Do you miss being a surgeon? I mean, listen, I'll always be a surgeon. You can never take that away from me. I did it for 20 some years. I loved being a surgeon. There is no greater privilege than being a surgeon. I mean, people literally go to sleep, put themselves in the most vulnerable position possible, and entrust you with their life. It is the most beautiful gift that God could have ever given me. What a tremendous, amazing privilege. But I also had the privilege to do that for 20 some years. And now I am able to help women have health that they didn't have their whole lives, to know an entirely different existence, an existence that is so much richer, so much fuller, that I consider myself to be one of the most privileged people on earth because I've had such amazing opportunities and my life has so much purpose.
Well, it's an incredible story. You know, back in medical school, as I'm sure you remember, there's sort of, you know, this cutoff before you go to residency. Like, are you going to go into medicine, some type of medicine, whatever it is, or are you going to go into some type of surgery? And I knew early on I was not going to be a surgeon. And so I think you're the first surgeon that I've met turned functional medicine physician, because there is such a, you know, distinct, I don't know if you want to say identity, you know, crisis that happens in this moment that people choose, like they're going the surgery path or they're going this medicine path. And so for you to go the surgery path and then, you know, change to a medicine path, the functional medicine is, you know, very interesting. And I'm glad you found functional medicine. When I, of course, was starting out and I got Graves' disease, there wasn't functional medicine. You know, this was back in 2004,
I know.
2005. I mean,
you blazed the path.
So, well, I don't know about that, but I definitely, you know, did everything that I could to find something like functional medicine, because I too didn't want to go through that. But, you know, in all of my research, and I even had, you know, friends of friends with Dr. Andrew Weil and reached out to him, and there was just nothing that I could find. And so, you know, it is one of the joys of, you know, I sort of turned my lemons into lemonade and have helped many people not have to go through what I've gone through. So, and incredible that you've then since changed your practice. So you focus, you know, very much on breast cancer, which is also so needed. You know, before we get into the rise of breast cancer, I think everybody kind of knows what breast cancer is, but there is, as with many things, a spectrum, right? You know, from these abnormal cells up to very different types of breast cancer. So can you kind of talk to us about, and you even mentioned it's a normal process, you know, within this particular type of environment. So how do you define breast cancer?
I don't think that people really do know what breast cancer is. I think it's a very common word. And I think it's something that is highly, highly, highly misunderstood, because people think of breast cancer as having a bad breast, right? Something's dysfunctional in the breast. But actually, the breast and the thyroid, for that matter, they're the canaries in the coal mine. They are simply reflecting what is going on in your body if you have exceeded your toxic load, your allopathic load. And so they're basically messengers. More than anything else, they're messengers. The breast in particular is a messenger because when we think about the makeup of the breast is made up of 4 tissues. So it's a glandular tissue. It's that milk-producing tissue. It's fat. It's connective tissue that's holding everything together, and that's in a skin envelope. So even in women who have dense breasts, and I do want to come back and talk about what that means later.
Okay.
But even in women who have dense breasts, who have a high proportion of glandular tissue in the breast, they're still going to have a lot of fat cells in the breast. And fat cells are where we store our toxins. So think about if you were living next door to a hoarder. Eventually, that hoarder is going to run out of space and it's just going to spill over onto your lawn. That's the same thing that's happening in the breast, is that these glandular cells are living next door to a toxic waste dump. And it is eventually, the more toxins that build up, it's going to spill over and it's going to have detrimental effects on those cells. Those cells are going to become damaged. Now, that alone will not cause breast cancer because breast cancer doesn't happen in a vacuum. We have a built-in immune system that is constantly on surveillance for damaged cells and is supposed to recognize these damaged cells in their infancy and destroy them and not allow cancer to get to a critical mass. But unfortunately, our immune systems in this day and age, they're exhausted because our immune systems are so busy putting out fires everywhere that they're like the fire company that's been working all night and they just don't have the bandwidth anymore. It's the same exact thing. 70% of our immune system is housed in our gut. Our gut is one of the biggest places where we come into contact with toxins. So if you are eating a diet that is highly processed, the standard American diet, or you're just not eating the right kind of diet for you, your immune system is exhausted. And if your immune system is exhausted because it's constantly having to process what's coming in your gut, or you're not making enough digestive enzymes and you're using your white blood cells to digest your food, or you're a grazer and you're eating all day long, so you're constantly asking your immune system to check out what's going on to see if that is food or foe, it's not going to be able to catch that cancer in its infancy. So it's the combination of toxic overload, which is preferentially stored in the breast, combined with an immune system that's just not intact, that's just overworked. And that is the recipe for breast cancer. And that is why it's happening more and more frequently, because our environment is more and more toxic. And instead of living in a parasympathetic state most of the time, we're supposed to be in a parasympathetic rest and repair state 95% of the time, but we're nowhere near that. We're more like 50-50 these days. And that, again, is not a recipe for success. When you are in that, we only know two states. We know danger and we know safety. And when you're in that danger state, you are cortisol dominant. That's our stress hormone. And when you're cortisol dominant, your body thinks that you need to run away from a saber-toothed tiger. We're modern beings living on a very old gene code. So if you're running away from a tiger, you don't need to fight off a cancer. That tiger's going to kill you. You don't need to fight the common cold. You're about to be gobbled up. But the problem is, we don't just run away from one tiger 5% of the day. We run away from tigers 50% of the day. And we never get a chance to rest, repair, relax. We never get a chance to get back into safety. And this is the problem.
You've already basically answered it, but just to be clear, breast cancer is on the rise. We are not getting better at diagnosing this.
That's a whole other question. Breast cancer is on the rise in terms of we're definitely seeing more of it because our environment is more toxic. We're not living on our grandmother's earth. We're not even living on our mother's earth. So there's definitely more toxins and more breast cancers as a result. However, what we see more of than anything else is overdiagnosis of breast cancer. Because when you look at the statistics, the exact same number of women die of breast cancer every year. And the thing that's increasing is the number of women that we treat for breast cancer every year. So that begs the question, do those women really need to be treated? Are we really impacting their life? And how are we impacting their life? Because it doesn't appear that we're saving them from breast cancer. And when you take a woman and give her a breast cancer diagnosis and obligate her to our current treatment paradigm, which is surgery, chemo, anti-hormonal treatment, radiation, you are shortening her lifespan and you are significantly diminishing the quality of her life, which will also shorten her lifespan. So we are not saving lives in our current screening paradigm. We are actually costing lives. And women who are treated for breast cancer are 2 to 3 times more likely to die of heart disease than women who are not. That is twofold. Certainly, the same kind of inflammatory changes that lead to breast cancer also lead to heart disease. But the other side of it is that almost all of our treatments for breast cancer cause heart disease, accelerate cardiovascular disease, accelerate cardiomyopathy. And that's a real problem because we are taking something that would not have affected the length of someone's life, and we're actually giving them a worse prognosis. So I think that we need to do a lot of work around how we diagnose, how we treat, and how we screen for breast cancer.
Well, yes, I definitely want to dive into screening with you. Before we do that, I mean, we're sort of talking about breast cancer as a whole, and there are, hormone receptor positive breast cancers. There's, triple negative breast cancer. There's just, in situ. So why don't we kind of break down, when you're saying we're getting overdiagnosed, do you believe that there's a number of women who, really shouldn't almost be doing anything, or maybe then just taking this functional medicine approach? We talked about the spectrum. So can you kind of break down the spectrum of breast cancers for us?
What I want to be most clear about is that when we talk about breast cancer being on a spectrum, that's absolutely true. But know that breast cancer is what it is from the beginning. So it's not as if it starts small, grows to some critical mass, at which time it's more likely to metastasize. The biology of breast cancer is what it is from the beginning. And it's not like it's going to become an atypical lesion and then move on to become DCIS, which is what is termed a non-invasive cancer, although I would argue that we shouldn't be calling it cancer at all. And then, it's obligated to next move on to becoming an invasive cancer. That's actually not the way it works. So things are what they are from the beginning from breast cancer. And if it's going to be an aggressive process, it's going to be an aggressive process from the very start. And if it's not, it's not. So for instance, we're diagnosing 40,000 women a year with DCIS. Now, DCIS is a non-invasive process where you have increased growth of abnormal cells within the ducts. But when they are within the ducts, they have no access to the bloodstream. They have no access to the lymphatic system because those structures exist outside of the ducts. That's how breast cancer spreads. So they have no ability to spread beyond the breast. And most of them do not or will not go on to become invasive cancers. So most of them, even if you do nothing, will stay within the ductal system. That's 80% of them. And yet, we are taking 100% of women diagnosed with DCIS, and we're committing them to treatment. So even though the DCIS would not shorten their lifespan, treatment does. Treatment does. And women who are treated for DCIS have a decreased survival as compared to women who are not. So this is a problem in and of itself. And then we talk about invasive cancers. So there are different types of invasive cancers. There's invasive ductal carcinoma that is named because of the way that it looks under the microscope. So if it starts to form ductal structures, even if they are not mature ductal structures, we call that invasive ductal carcinoma. If they line up in sheets, we call it Indian filing. If they line up in sheets, then that's an invasive lobular carcinoma. But it doesn't matter which tag you put on it because they're all treated the same way. Now, there are some biologic prognostic factors that we use to help to guide treatment, in that you mentioned hormone positive. What we mean when we talk about hormone positive cancers is that they have estrogen and progesterone receptors on their surface. But we need to say two things about that. First, it is normal for breast cells to have estrogen and progesterone receptors on their surface. And cancers that have estrogen and progesterone receptors on their surface, even if they have more of them, an upregulation or an increased number of estrogen and progesterone receptors on their surface, that is a variation of normal. That means that that cell has maintained these normal characteristics. That's a good thing. That's why they're prognostically better than a cell that is triple negative or hormone receptor negative, because that cell is a big departure from a normal cell. We're supposed to have estrogen and progesterone. So I don't want to confuse the presence of receptors with your hormones cause breast cancer, because it's simply not true.
Okay.
If we take nothing away from today, I hope we take away from today that estrogen does not cause breast cancer, and association is not causation. So if estrogen caused breast cancer, as estrogen, and I'm using that catch-all term, there are actually several estrogens that we have in our body, but just for the sake of this discussion, let's just use it as a catch-all term. If estrogen caused breast cancer, that would mean that women were put on this earth for the sole purpose of developing breast cancer.
Right.
When we see breast cancer, we see the majority of it in the postmenopausal state where estrogen levels are barely measurable. If estrogen caused breast cancer, we would expect to see it in teenagers when estrogen levels surge, but we don't see it in teenagers. If estrogen caused breast cancer, we should see it in pregnant women who have 10 times the estrogen levels of non-pregnant women. And yet that's not what we see at all. And breast cancer in pregnancy is fairly rare. So we need to unlearn that misunderstanding and just know that when you have estrogen receptors on your tumor, it's just a variation of normal.
So my understanding, from practicing and looking at female hormones and risk factors for breast cancer is really the metabolites of estrogen. As we're metabolizing out our estrogen, it's, looking at these bad estrogens or bad metabolites versus, the ones that are not. And that is just amongst much of the other things that you have mentioned, the toxins, the stress, all the other things. It's also this exposure to the poor metabolites throughout your lifetime versus the exposure to, as you said, estrogen, estradiol, estrol, things like that.
That is definitely a part of it, in that when we break down our estrogens, we do break them down to metabolites that are known carcinogens. However, that doesn't explain why we see most of our breast cancer in the postmenopausal phase when we have very little substrate even there. So if it's a endogenous, meaning our own hormone breakdown issue, why are the metabolites suddenly toxic when we've gotten through, 50, 60, 70 years without that happening? And the reason is because when we use that system to break down our hormones, we also use that system to break down xenoestrogens or environmental estrogens. And this ends up being the major problem for women because we are literally swimming in a sea of toxins. And these xenoestrogens, these environmental estrogens, these synthetic estrogens are surrounding us and making us exceed our ability to clear these effectively. I heard something from Dr. Felice Gersh. I don't know if you know her, but she made a comparison between taking a synthetic birth control pill, because we know that birth control pills are associated with an increased risk of breast cancer. And she said that essentially that is the same as grinding up your credit card and eating a little piece of it every day, because it's the same synthetic estrogen. Mm-hmm. And our body knows what to do with our endogenous estrogen, right? That picture is pretty clear to us. Are there some people that struggle with that process? Yes, for sure. However, the far more important thing, the far more worrisome thing are all the endogenous or all the xenoestrogens, the exogenous estrogens, the ones that are surrounding us. It's the plastics and the fragrance and the non-stick and the flame retardants and the pesticides and the herbicides and the fungicides and the antibiotics. And we can go on, right? And it's the average woman puts 150 chemicals on her skin in the morning before she even gets out of the door to go to work. So this is a major problem, and our livers are just being totally overtaxed, totally overburdened. And it's the breakdown products of these xenoestrogens that's really leading to the spike in breast cancer incidence.
Let's get into screening. You know, this is maybe for some not a very controversial topic because they know just go get your mammography or your mammogram. And for others, it is a controversial topic. You and I were talking before this. You know, I'm a person, I have done mammograms. I'll probably stop now after talking to you, and thermograms. And I've seen people who, you know, have had positives on thermograms, but not mammograms, and vice versa.
Yeah.
Which is why I always recommended, you know, certainly for a high risk person to do both. But what are and there's some exciting opportunities that are coming available that we can talk about as well. But yeah. Prior to this new technology, which you'll talk about, this QT imaging, you know, what was your recommendation for women as screening?
So the first thing I wanted to say is that if you are high risk, that means that you are more susceptible to environmental insults. And one surefire way to make sure that you get breast cancer is to get a mammogram every year and to get radiated, because we know that people who are high risk don't do well with radiation. They have problems combating radiation. They have problems repairing the damage from radiation. And I'm talking about people with BRCA mutations, people who have had cancer in the past. We already know that they struggle with repair. So this is a surefire way to make sure that they get breast cancer is by doing mammographic screening every year. I do want to talk about mammography a little bit, just because, you know, it is the gold standard and I understand why, but that is another place where we need to unlearn, because we're told that mammograms save lives and it simply isn't true. So the mammographic screening program that was started in the 1970s was built on a foundation that believed that breast cancer growth was both linear and predictable. And like we talked about before, that is not true. So that foundation believes that breast cancer starts as something small, grows to some critical size, at which time it is more likely to metastasize. And if you can find it earlier, you can save lives and save breasts, because people will not die because you've discovered it early, and people will have less treatment. And neither one is true. We are not saving lives and we are not saving breasts. So no matter how many mammograms we do every year, the exact same number of women will present with advanced disease. No matter how many mammograms we do every year, the exact same number of women will die of breast cancer because breast cancer is what it is from the beginning. And if it's going to be an aggressive process, it's going to be an aggressive process from the very beginning. And just because you find it when it's small doesn't mean you're going to change the trajectory of that disease. At the same time, you are going to find a lot of women who have cancers developed in their breast that don't need treatment. And once you commit them to treatment, you are changing the quality and the duration of their life. And then they die of complications of treatment. And so for every 2,000 women that you screen, you may find one woman whose life you save, and you're going to cause 10 women to be treated and suffer the consequences of treatment. And these are unacceptable numbers. Mm-hmm. Absolutely unacceptable numbers. So when I talk, and the reason that mammogram is a problem is because it's an X-ray. It's radiation. I mean, we gave it a really nice name, right? We gave it mammogram, picture of the breast, but it's an X-ray. It's an X-ray like anything else. And when you go for an X-ray, if anything else, they cover you in lead, but not a mammogram. And people often say, well, do you tell your patients not to fly cross country because it's the same amount of radiation as people get on a cross country flight? Yes, that's true. But on a cross country flight, that's scattered radiation, which has a totally different impact than when you are focusing down the radiation on a compressed breast. So you're already traumatizing the tissue, and then at the same time you are radiating. And every time we radiate, especially with low energy radiation, like what is used in a mammogram, a percentage of that radiation will be retained in the tissue. And so it builds. It builds and builds and builds and causes DNA damage, which in and of itself would not be a problem, except that our immune systems are exhausted. Mm-hmm. And so that combination is the perfect recipe for breast cancer. And unfortunately, industry wants it that way. The breast cancer industry is a huge, huge industry, and they want patients, and they're getting them. Mm-hmm. So I am not an advocate for screening mammogram ever. I don't think there's ever a reason to do screening mammogram. That does not mean that no one will ever have a mammogram again, because I'm not throwing the baby out with the bathwater. And if you have an issue with your breast, if you feel something, if it's changed in appearance, if it is sore, if you feel a lump, if you have nipple discharge, if you have a symptom, that's not a screening mammogram. That's a diagnostic mammogram. You're trying to figure out what's going on. And when you're trying to figure out what's going on, we should use everything that our system has to offer. And I have a radiation protection protocol that I advise everyone use. I tell them to take high doses of melatonin, high doses of vitamin C, high doses of vitamin E, glutathione. I tell them to do all of these things to protect against the free radicals that are generated when you undergo radiation. But I don't tell people to not get worked up for a diagnostic study. Now, if you're just talking about screening, here's what I would have told you a year ago. I believe in self-examination. I think that the patient is the doctor of the future. I think that no one is going to know you better than you know yourself. So if you are examining your breast every month and something meaningful arises, you're going to know about it. So I completely advocate for self-breast examination. Most people want to do more than that. Most people don't feel comfortable with that alone. They're afraid they're going to miss something. Their breasts are lumpy. Whatever the motivation is, they want to do more. They want to feel active. That's fine. So a year ago, I would have told you to have a thermogram and an ultrasound. I think thermogram gets a really bad rap, and I hear story after story after story about how thermogram missed my cancer and it was only picked up by blah, 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 blah. That's true, because thermogram is not a screening test for breast cancer. And we have touted it as a screening test for breast cancer, and simply not true, which is why it got this bad rap. Thermogram is a heat sensor. It is looking for heat differentials. It is a screening test for inflammation. Mm-hmm. Now, there are lots of cancers that are growing at a rate such that they are going to increase their metabolism and put off a heat signal. And those will be found with thermogram and then confirmed with an ultrasound. But if you have a very slow growing tumor, it's not going to be seen on thermogram because it's not going to be metabolically active and it's not going to send off a signal. So I love thermogram as a screening examination to know where are you on the inflammation spectrum. Because as you and I both know, we need to be very mindful of the amount of inflammation that we have in our body. You don't want none, but you don't want too much. It's a balance. It's a dance. It's a symphony. And we want to make sure that we're staying in tune.
And are there other sources of inflammation on a breast thermogram that is not cancer?
Absolutely, 100%. So an infection will show up. If you're breastfeeding, that is a hypermetabolic state. You can see it. You can see changes with lactation. There are lots of reasons why you might have a hypermetabolic state. It can also precede what will eventually be the manifestation of breast cancer by years. Mm-hmm. So some people can have inflammatory changes in their breast and not have a physical lesion that is seen. Mm-hmm. So I fully believe in thermography, but if you're using it for breast cancer screening, then it needs to be done in conjunction with an ultrasound. I don't pair it with a mammogram because I don't think that we should be subjecting the healthy population to unnecessary radiation. And that's my biggest objection to mammogram is that when we're talking about the screening population, we are talking about healthy people. And it is immoral to subject healthy people to something that causes cancer. We can't use a test that causes cancer to screen for cancer. It's just not the right thing.
And so with a thermography or thermogram, you can walk in and order it yourself. And I think generally you have to pay out of pocket. It's not insurance covered. An ultrasound, on the other hand, my understanding is that generally that needs to be ordered by a doctor. I'm not aware of places, maybe you know some, where you can walk in and get your own ultrasound like you can a thermogram. But, what do you... do you know of any place that you can go just walk in and get your own ultrasound? But two, finding a doctor that is willing to write you for the ultrasound, right? Because they're so ingrained with mammography or a mammogram. So
I think things are changing. They may not be changing quickly enough for everyone, but they are changing. And if we are partnering with our doctors, then we can often find that relationship of trust. What doctors are afraid of when they are not recommending mammograms is that, a little bit they're going off the standard of care. A little bit they are, they probably have an obligation. A lot of doctors are employed by hospital systems, by big practices, and they are obligated to use certain protocols. But if you can find a doctor to work with you, they often, once you explain your position, and again, things are changing, they often understand. There are also some thermography suites that offer ultrasound at the same time. And I'll refer you to a documentary called Boobs, the documentary by Megan Smith. Do not Google boobs. You will not like what comes up. But if you Google Boobs, the documentary, this is, I think she did a really, really amazing job at kind of pulling the curtain back on the mammography industry and what it's all about, and safe ways to screen for breast cancer. But none of this is going to matter because there's new technology available that's FDA cleared, that is safe, that's painless, no compression, no radiation, fast, affordable, and has 40 times the resolution of MRI. It's called QT imaging. It is the only imaging that is functional in that if you have a finding in your breast, we can bring you back in 60 days and do a short interval study. We can count cells. We can actually see things on a cellular level. We can measure a doubling time. And we know that cancers have a doubling time of less than 100 days. And things that are either not cancer or not meaningful have a doubling time of greater than 100 days. So if you have something with a doubling time of greater than 100 days, we say, see you in a year. And we are saving women from unnecessary biopsies, from unnecessary diagnoses, and from unnecessary treatments. So there are several centers open in the United States currently, and I am making it my mission to allow every woman who wants access to QT scan has access to QT scan, and I'm opening up centers all across the United States.
If you can't get to a QT center, requesting the ultrasound if you can, and doing a thermogram if you can. And then as these QT centers are open, in your area and more accessible, I think you and I were just discussing one of the locations that open has a 6-month waiting list. So, there may not be people who can either get there or wait. And so looking at thermogram and ultrasound.
Yes, but don't discount self-examination. Because if something is going to be clinically relevant, it's going to be palpable to you. And when we look at the studies that are done, the Swiss studies in particular, they compared the population of women that screened to the population of women that did not screen. And they both had access to the same medical care afterwards. Both access and quality of care was the same. The only thing that was different was the women that screened and the women that didn't screen. And for the women that screened and the women that didn't screen, outcomes were exactly the same. They found more breast cancers in the women that screened, but the number of women that died of breast cancer was exactly the same in the screening group and the non-screening group. So the screening group didn't save lives. It just cost more women to be treated for breast cancer. And the differential between the size that they found on screening and the size that they found with just self-examination was 4 to 5 millimeters. So that is a meaningless size differential. So we are not, it is not making a tremendous difference to screen with imaging. And self-examination is adequate, and it's certainly better than putting yourself in any danger. So if all you can get is a thermogram, that's all I would do. If you are just doing self-examination, that's fine. And when QT is available near you, and we know that that is the safest, most effective way to screen, and this will forever change how we screen for breast cancer.
And the QT, is it only for breast cancer? Is it only screening your chest, or are you able to screen anything else?
So right now, this machine only screens for breast cancer. In 2026, the whole body scanner will become available, and that will screen everything. And that will forever change how we image the body. It will replace MRI. It will replace CAT scan, because there will be no reason to use gadolinium and expose yourself to a heavy metal. There will be no reason to use CAT scan because you would not want to expose yourself to radiation. We know that people with CAT scans have a 10 to 20% increased incidence of cancer as compared to the general population. So this will replace all of that in a way that it is completely safe, completely painless. And I mean, what parent isn't going to want to have their newborn imaged just to make sure that everything is okay? What orthopedic surgeon isn't going to want to have the answers in his office at, in 4 minutes so that they can do, I didn't mean to say he, she, there are women orthopedic surgeons too. But what orthopedic surgeon isn't going to want to have the answers in their office immediately so that they can diagnose what's happening with people? I mean, right now, I don't know. We spend a lot of time in the orthopedic surgeon's office between me being a weekend warrior and my children are student athletes. So, go to see the orthopedic surgeon, get a prescription, have to go schedule the MRI, go have the MRI, get the disc, bring it over to the surgeon, have to go back for another appointment. Like, this will get rid of all of that. So this technology is going to forever change how we image people. And it's doing it in a completely safe way. So it's really amazing. And I'm so privileged to be on the forefront of it.
What at this moment, and I'm sure as this rolls out and there are more places and whatnot, the cost will go down. But what is the cost now for a screening?
Depends where you are geographically, but it's somewhere between $400 and $600.
Not necessarily affordable by all at this moment, but certainly hope to get there.
But if you're paying for a mammogram or you're paying for an ultrasound, it's far less than either one of those things.
All right. Well, you have a new book coming out, The
Right.
Smart Woman's Guide to Breast Cancer. And in that you talk about, okay, if you get a diagnosis, short of, some of the really extensive invasive ones, but if you get a breast cancer diagnosis, like, first of all, breathe. Second of all, start a juice cleanse as you're sort of figuring out your options. So one, can we talk about, the purpose of the juice cleanse, why you recommend that? And then what are people's options? Have you had women come see you exclusively and reverse their, either stop or reverse their breast cancer? And if so, can you walk us through what you're doing with them?
Yeah, absolutely. So with great exception, breast cancer is not an emergency. It feels like an emergency. It's maybe an emotional emergency, but it's very, very rare to be a physical emergency. So I want to talk about the 3 instances that it is a physical emergency, because those are the times when people really do need to seek immediate treatment. So first of all, if you go from having a normal breast to a breast filled with tumor that is red and swollen and painful, it has something called peau d'orange, like the skin of the orange. It's dimply. That is inflammatory breast cancer. That is a clinical diagnosis. You don't need a biopsy of the skin to prove that there's cancer in the skin. We can look at the breast, see that it is swollen and red and clinically meets the criteria. And then, you do a biopsy of the breast tissue. There's an underlying breast cancer. That person needs to make decisions and get into treatment within days. This is a rapidly progressing process. It doesn't mean that it can't be treated and can't be reversed. I've seen it be reversed time and time again, but that person needs to rapidly get into treatment. And that is one of the times when I absolutely advocate for chemotherapy, along with some functional medicine add-ons, plug-ins, if you will. But I think of chemotherapy in that case as their proverbial sink is overflowing, right? They have lots of tumor burden. They need a quick fix. And this is how you mop up the floor. And then I work with them afterwards to shut off the faucet, to figure out what is driving this disease. But inflammatory breast cancer is one of those instances. The next instance is if you have breast cancer that is spread to the bone, you don't have bone cancer, you have breast cancer that's spread to the bone. That itself is not an emergency. But if it's causing a fracture and you're in major pain, it is impossible to heal if you're suffering. It's impossible to heal if you're in pain. And so those people need pretty rapid treatment. Most of the time, that's radiation in order to stop that process, maybe reverse that process, and get them comfortable, get them feeling better so that they can start to heal. The third instance is if you have brain mets, because the brain is in a fixed space, it's in the skull. And so if you have brain mets, you have brain swelling, and if the brain swells so much that it cuts off the blood supply to the brain, that is not a survivable condition. So people with brain mets need to be treated right away, again, usually with radiation, to try to reverse that situation. And even in that instance, I have seen people reverse their disease. So everyone else, if you don't meet those criteria, everyone else, I tell them to breathe. I tell them to pause. I tell them to take the time, read my book, The Smart Woman's Guide to Breast Cancer. Learn about the disease. Learn about what you have. Start to think about your why. I do talk about a juice cleanse, even though in the long term, I don't believe in juice because juice is just sugar. It lacks fiber. It does not have the qualities that I think are important in a long-term diet. But this juice cleanse is actually a fast because we know that the quickest way to healing is fasting. So I have people on a very low calorie juice cleanse. And if they can do it for 3 days, 5 days, a week, 2 weeks, 3 weeks, while they're figuring everything out, it will start to turn their disease around. First of all, it will get rid of a significant amount of inflammation. It's kind of, it's my way of compromising, instead of doing a water fast because people are so adverse to water fasts. But that is a great way to start to turn it around. Breast cancer is an environmental disease. Breast cancer is a metabolic disease. And this helps to detox. It helps to correct the metabolic dysfunction. And it really gets the people on the path to healing. So that's why I tell them to start with the juice cleanse. I love Chris' work. He wrote Chris Beat Cancer. He's a brilliant guy. He's saved the lives of hundreds of thousands of people for sure. He's a big juice guy. We don't agree on that point, but it worked for him, right? And he advocates it for a lot of other people. I just think that if you're going to, and it does give you some nutrient, but if you're going to eat the food, I think we should eat the food. I think that we should eat the food in the most unprocessed way. And I think the fiber is really important. So what I tell people after they've taken a breath, taken a pause, getting educated, doing that fast, building their team, because it's so important to identify the people that are going to help you along this journey. Then we just need to think about our why. That's really important to identify why we have breast cancer, why we have dysfunction. Health is not the absence of disease. Health is optimal function, and that's our goal, to get you back to optimal function. Stop focusing on the tumor, focus on the inflammation, focus on why you're inflamed, focus on what could be driving the process. Ask a lot of questions, but then think about getting those pillars into place. And that's what my book is about. It's about putting those pillars in place, teaching you how, when, and what to eat, how to move, how to sleep, right? Sleep is so undervalued in our society, and yet sleep is where the healing happens. And if you're not sleeping, you're not healing. Mm-hmm. Learning healthy ways to manage stress. We talked about before that we are living 50% of the time in this cortisol dominant state. This is not the recipe for success. This is the recipe for disaster, right? Mm-hmm. We need healthy ways to manage the stress, and we need to get into healing more than we're in danger. Mm-hmm. So things like meditation, things like gratitude, all of these things help you to build that skill set so that you can spend more of your time in that rest repair state. And then we talk about toxins and how to clean up your environment. And you know how important that is, because we know that toxins are a root of significant disease for a lot of people. And in particular, the things that I think about when someone gets a breast cancer diagnosis is what's happening in your mouth. Do you have dental amalgams? Do you have heavy metal burden? Have you had root canals before? Do you have chronic inflammation in your mouth and your gums? Do you have bone infections? Do you have cavitations? These things are very real and often associated with a breast cancer diagnosis, and we're not talking about them enough. What's happening in your gut? Do you have parasites? Parasites are almost ubiquitous, and yet we're walking around, we're not talking about it, we're not treating it. Do you have chronic constipation? If you have chronic constipation, you are holding on to so many toxins and not getting rid of them. This is a huge issue. Are you moving your body enough? If you're not moving your body enough, then you're not getting rid of the toxins. If you don't move your body, you lose it. So movement is a huge part of what we talk about. And then ultimately, it comes down to, are you living your life with purpose? We were all put on this earth for our own individual mission, and no one's mission is more important. And I'm not going to be the best version of you, and you're not going to be the best version of me, right? We all have our individual mission. No one's mission is more important because it takes everyone. It takes everyone and everyone's contribution to make this all work. So all you have to do is be the best version of you, whatever that is. If you're raising children, if you're farming, if you're a gardener, like, it doesn't matter. Just be the best version of you and live your life with purpose. And when you do that, that's actually the recipe for health. And so I don't think about treating disease because that's not my goal. My goal is to establish health. And I think about all the things that we do to build health. And I think about the things that are getting in the way of that and help to take away those barriers. So I have a practice called Real Health MD. And this is where I help women all along the spectrum of breast cancer to restore their health. And I've had women who have been diagnosed 5 years ago with metastatic disease that have no evidence of disease. And I have women at every stage in their journey. They were just diagnosed. They're mutation carriers and they don't want a diagnosis. They are completed treatment and they're wondering, now what? They were treated years ago and they don't want it coming back. Or they're living with metastatic disease, and everyone in between. And again, my goal for everyone is the same, but everyone's journey is so different. So as a physician, we have to meet them where they are.
And so for those people who do want to opt for, the various, let me back up and say one of the things that I loved that you said in the book about a mastectomy was, really thinking hard about that and how, if you opt for something else, you may one day sort of forget that you ever had breast cancer. But if you have this mastectomy, you're going to have this reminder. So that was, I thought pretty powerful.
Yeah.
So for the people who are considering chemo, radiation, maybe tamoxifen, and of course, each of those things is different, but how do you support people? Are there supplements, foods?
Yeah,
I know
absolutely.
You're a proponent of intermittent fasting that people can do as if they are choosing sort of going a conventional route or maybe doing part conventional, part functional medicine.
it's not an or, right? Everyone is going to make the decision that is the right decision for them. And we make the best decision we can at the time that we are faced with that decision. And so I don't talk about mastectomy or lumpectomy or, whatever other treatments or alternatives in the context of making someone regret their decision, because we really do make the best decision that we can at the time that we make it. But that I hope to prevent someone from making a decision in the future that they would regret. And I never tell people to not undergo those conventional treatments. I don't tell them to not undergo surgery. I don't tell them to not undergo chemotherapy or radiation. But what we need to understand is that cancer is not a surgery deficiency or a chemo deficiency or an aromatase inhibiting deficiency or a radiation deficiency. And none of those things are ever going to make anyone healthier. So for me, it's not an or, but it's an and. Maybe you need surgery and you need to consider your diet and your movement and your sleep and your toxins and all of those things that we talked about. Maybe you are living with metastatic disease and for a short period of time, you're going to consider chemotherapy or an aromatase inhibitor or tamoxifen. But what I don't believe is standard protocols for everyone. So for instance, I had a woman recently who had a 10 centimeter tumor in her breast, so came into the process with a large amount of tumor burden for sure. She had 2 rounds of chemotherapy and the cancer was gone. There was no evidence of cancer on physical examination or on imaging. And yet her doctor wanted her to finish the 12 rounds of chemotherapy. This is where our system has gone wrong because we're not looking at the person in front of us. We are following the protocol. We're checking the boxes. And this is a huge problem. So in her 3rd and 4th rounds of chemotherapy, because her doctor forced her into it, she developed neuropathy. So we're not listening to what the patients are saying to us. We're not observing what we're seeing. We're not internalizing it, and it's a huge problem. So where I land is, let's do the best thing for you that you need right now. And then, if it comes back and you need it again, it's always an option. But I don't believe in over-treating people, and I don't believe in doing more. And when I said that mammograms don't save breasts and don't save lives, this is what I mean. Because it puts women in these situations where they're getting overtreated and there are prices to pay for that. These drugs that we use that kill cancer also kill a lot of normal cells. Mm-hmm. And you can't live without your heart. You can't live without your brain. You can't live without your bones. I just want people to know that there are ways that we can make those treatments better. If you are going to have chemotherapy and that's what feels right to you, great, I support you. But let's make sure you're fasting while you're getting the chemotherapy, right? Let's make sure that you're taking the supplements that we know sensitize you to chemotherapy while at the same time protecting your normal cells. Because this is what ends up being important. And you're not getting that from your doctor. Most of the time, your doctor is telling you, no, don't take supplements, and not thinking about the fact that when you're getting radiation, we actually know that turmeric is really protective and that you should be taking it, right? And that you should be taking melatonin the whole time, and you should be taking vitamin D the whole time, and you should be taking ashwagandha the whole time. But they're not talking about that. They're not talking about the value of medicinal mushrooms in the course of your cancer treatment, despite the fact that medicinal mushrooms are used in cancer treating protocols all over the world, just not here, because you can't monetize a molecule of nature. And so we let the system get in the way of doing what's best for the patient. And what I'm trying to do is to introduce these principles into treatment so that it becomes mainstream. And I can, to some extent, use my platform to do that because that's where I came from. I speak both languages, and I have the
And
unique privilege of speaking both languages.
You do. And it's so helpful because, I certainly, coming of a background of an ER doctor turned functional medicine physician, when I had people coming to me that were going through cancer treatments or wanted to help, post-cancer, I always felt way more comfortable post-cancer, in terms of helping them detox or, prevent. But, it definitely made me nervous because, I wasn't trained as you are. And it's, a lot of cancer's scary and it's a lot of liability, right?
Yeah.
I mean, a potential liability.
Yeah.
And you have the oncologist saying you can't do this and don't do that. And as you know, it's a blanket statement about supplements, right?
Yes.
Like they really don't even
look. It's a blanket
like,
statement.
Yeah. Maybe you don't want glutathione because it's going to detox out the chemotherapy, right? So maybe you don't want that right now because you want the chemo to work.
But that is something that someone that is well-versed in this knows. And the bottom line is that we need to start working together. We need to be far more cooperative. It can't be us and them. It needs to be us, right? We need to be collective. We need to be unified. We need to start doing the right thing for the patient and stop fighting over whose turf it is, right? Like we can't have turf wars here. But more importantly is that we need to stop saying no when what we mean is, I don't know. Because when the medical oncologist says no, but means I don't know, I know, right? And so that's a situation where I'm now having to overrule their doctor and I'm interfering with that relationship. And it shouldn't be that way. We should all be on the same page. And doctors need to be far more comfortable with saying I don't know when they don't know. And it's something that needs to be learned, right? Because we all felt like insecure about it, like we should know.
Well, hopefully, people, I don't know if you've gotten the feedback yet, but as people are, taking your book in to their oncologist, hopefully they are getting, I don't know, or that doesn't seem like it's going to be hurtful. This seems reasonable. I know that when people would take my books coming as a background as an MD, not a different degree, I certainly don't want to knock on any other degree, but, I got the feedback that doctors were more open, particularly with my thyroid book, to order maybe the reverse T3 or the free T3 that normally they wouldn't have ordered, but they brought in the book. And so I hope that you're getting feedback from your patients that their doctors are at least somewhat receptive.
I think that patients are taking more time and finding the people that are receptive. And this next generation that's coming up, it's unlike when I trained. It's probably unlike when you trained. You trained after me. They're more open. They're more open. They know that it's not so cut and dry as it was when we were taught. And they know that there's more. And so I'm really hopeful for the future. I'm hopeful for what medicine is going to morph into. Because it needs to be about the patient. And for a long time, it wasn't. Now,
absolutely,
it's not all sunshine and roses. I know that. But things are changing. Things are changing. And I know that they're going to change for the better.
It's probably on everybody's mind. It's certainly on mine. The use of bioidentical hormones, with either current cancer or post, someone who's already been diagnosed and treated with cancer. Your thoughts on that?
The person who's already been treated, that's a clear-cut answer, right? So if they've already been treated, if they have done the work, they're metabolically healthy, they're eating a diet that is nourishing them, their inflammatory markers are normal, You've optimized their nutrition. You've optimized their vitamin D. You know that they're methylating. You know that they don't have any active cancer. Their circulating tumor cells are zero. That person should absolutely be on hormone replacement as long as it's bioidentical, because we know that that is the key to longevity. We know that women who go on hormone replacement within 10 years of menopause or cessation of ovarian function, they have benefits to their heart, to their brain, to their bones, to their skin, to their libido, to their genitourinary tract. I mean, the benefits go on and on and on, and they translate to both longevity and to an increase amount of happiness, of satisfaction with life. That matters, right?
Okay.
If you like your life, you're going to live longer, right? So to me, that's a no-brainer. Someone who has recovered from breast cancer and is being properly monitored, no-brainer. Now, at the same time, I'm mindful of xenoestrogens. I'm mindful of not making sure that they're not getting extra radiation exposure, like doing all the things that we talked about today. The question is the person who's actively cancering. Either they have metastatic disease or they are actively in treatment. So that's someone that you're still working out the problems there. You're still figuring out their why. You're still trying to get them into metabolic health. You're still trying to get their inflammatory markers down. You're still trying to deem them disease-free. So I have a 2-year window in which I'm not even talking to them about hormone replacement because we have bigger fish to fry, right? We got to get you healthy. Because hormone replacement, in my opinion, is for healthy women. Mm-hmm. It's not going to make you healthy. It's going to keep you healthy, right? But you have to get there first. Mm-hmm. So that's kind of where I fall out. But the data says that women who take hormone replacement, bioidentical hormone replacement, are not more likely to get breast cancer. And if you do get breast cancer, because women on hormone replacement will get breast cancer, just like women who are not on hormone replacement get breast cancer. And since 2003, when the Women's Health Initiative was halted, we've only seen an increased incidence of breast cancer despite the precipitous drop-off of women who are on hormone replacement. So, that's not it. That's not it. But when we see women get breast cancer who are on hormone replacement, they have better outcomes as opposed to their counterparts that are not. And that's the same thing that we see in women with a history of breast cancer. Women with a history of breast cancer on hormone replacement are going to have recurrences, just like women who have had breast cancer and are not on hormone replacement are going to have a recurrence. However, a certain percentage, of course, not everyone. However, the women on hormone replacement after breast cancer have better outcomes. So we see it on both sides. So I am fully in support of hormone replacement as long as you've done the work, as long as you've figured out your why, as long as you've gotten on a nourishing diet, as long as you have movement, sleep, detoxification, and cleaned up your environment, you don't have any evidence of disease. As long as you've put the pieces in place, I think women should be on hormone replacement.
As we wrap up, I'd like to ask everyone 3 recommendations that you have for our listeners to take back their health.
The first thing that I want to say is that breast health is health. And the same things that are going to give you a healthy breast are going to give you a healthy heart, a healthy brain, healthy bones, healthy gut, all of that. And so if you focus on building health, then that is what you're going to get, because what we focus on grows. So that's the first thing, is just focus on your health. Ask, is this building my health or is this hurting my health? The second thing is that it's impossible to be healthy without a healthy gut. So you have to make sure that that is in line. I think that, if you have the resources to get a microbiome test, great. If not, you should be moving your bowels twice a day. You should be of normal weight. You should have a normal waist to hip circumference, which in a woman is 0.8. You shouldn't be carrying extra weight around your middle. So gut health and metabolic health is key, and pay attention to that. And then at the end of the day, we have to realize that health happens at home. It doesn't happen in a doctor's office or a hospital or anywhere else. Health happens at home, and the only person that can make you healthy is you. So that is both a blessing and a curse in that your health is yours. It's yours to gain, and it's yours to keep.
And how can our listeners find you, find your clinic, find your book, all the things?
Yeah. So my website is Real Health MD, and you can find all of our services there. If you want to apply to work with me, there is a link that you can sign up so that we can have a discussion and see if you're a good fit. I also have group programs where we go through my book, The Smart Woman's Guide to Breast Cancer, chapter by chapter, and I give people lots of access to me so that they can ask questions and get their questions answered. And then I have a podcast every week called Keeping Abreast with Dr. Jenn. So absolutely, if you like what you heard today.
Love the title.
Yeah, thank you. You can listen to me every week, and hopefully very soon they'll be able to hear you on my podcast. And then I have a Facebook group called Keeping Abreast with Dr. Jenn, same title, where we have thousands of like-minded women who want to really participate and take an active role in their health, but not only their health, they want to lift all the ladies up that are around them and help them with their health. So it's a really, really beautiful and very active community. So if you want to be there, we would love to have you there. And then you can follow me on all the social outlets. I'm Dr. Jenn Simmons, and my Jen has 2 N's. And again, pick up my book, The Smart Woman's Guide to Breast Cancer, and that's available on Amazon.
Well, it was great talking with you. I feel like I could have gone a whole nother hour, so I'll definitely have you back on again.
I would love
to get all the questions that we didn't get to. And thank you so much for joining us. And everybody, please, check out Dr. Jenn Simmons. I want to thank this week's guests for sharing their time and knowledge. And thank you for listening. To read the full show notes for each episode, which include a summary, timestamp, quotes, and any resources mentioned, please visit amymyersmd.com/podcast. Lastly, if you've enjoyed this episode, I'd love if you would leave a rating and a review on Apple or Spotify, and we'll select a few to read out loud in a future episode. Tune in next week to hear from another inspiring guest as we help you take back your health.